My name is Seyedin. I'm one of the radiation oncologists, like my colleague, Dr. Hong, who just gave a talk on primary prostate radiation therapy. My talk is going to be more focused on what happens, unfortunately, to some men who go through either radiation or surgery and their PSA comes back. And how do we approach that? So, kind of some of the goals of today's talk will be what we call it, how do we define a PSA recurrence? What does it mean when a PSA comes back, right? We're going to review what risk factors might increase that chance from occurring. And we'll kind of go through pretty much my more tailored approach to clinical and imaging evaluation. I won't talk too much about PETs here, just that I don't want to steal Dr. Hope's thunder, who's coming after me here. And then we'll talk about kind of various clinical scenarios and how I kind of think about treatment options for these patients, right? So what is PSA failure, right, or recurrence? It's also known as biochemical failure. Just depends on what you've had, right? As we kind of had from Dr. Washington, Cooperberg, and Carroll, after surgery, your PSA should drop to 0. So the typical definition of a PSA recurrence is a PSA that's 0.2 and then a secondary rise. Now, as our ability to detect PSA has gotten better, right, ultra-sensitive PSA, sometimes people might pull the trigger early of calling something recurrent, especially in the setting of like more aggressive features, which I'll describe in a minute. Radiation is different, right? And then some people often ask me why. It's probably just because when we radiate an entire prostate gland, some of the normal prostate tissue sticks around. And so what we do is we kind of get your lowest value throughout after treatment surveillance. And then if it goes above 2, so the nadir plus 2, we call this recurrence. But not all recurrences are real. So for example, often patients who get brachytherapy, which Dr. Hong talked about, these patients can have a bounce. And it typically happens around 18 months. And this kind of goes up and it goes back down. So, with new imaging, sometimes we pull this trigger even earlier, right? These definitions were made in the era without PSMA PET imaging. What are risk factors for recurrence, right? And some of these are shared by both surgery and radiation. So for example, I have some MRI features, and I think we did, Dr. Carroll did a really nice job of showing this. So for example, this is an MRI of someone's prostate that I kind of just traced in red. You can see here on this side, there's a nice kind of clear delineation of the prostate border, but not on this side, right? It's kind of lumpy and bumpy. And so we call extraprostatic extension, meaning this has not left the prostate region, it's just extending from it, right? And these regions tend to like to come back. Vice versa, or similarly, you have something called seminal vesicle invasion, right? And so during surgery, the surgeon will take out the seminal vesicle, we also treat it, but these are more signifiers of really aggressive disease biology, right? This next one is more of a surgical, obviously, risk factor. So what I'm trying to show here, and it's, don't take this as a prostatectomy, this is definitely not that, but just the concept of what a positive margin is, right? So sometimes when our surgical colleagues go in, the ideal situation is in situation A, where their cancer is surrounded by normal tissue. We call this a negative margin. And then we have scenario B, which does happen microscopically. Of course, we're talking about millimeters, where unfortunately at the edge of the specimen, this is where we get our pathology colleagues, really, that's why they're so essential. They know that there's tumor on the edge of the specimen, meaning that on the other side, there's probably cancer as well. Well, this increases the risk of the cancer growing over a period, maybe years, months, who knows. This next one is about the Gleason pattern. I know Dr. Ding did an amazing job describing what Gleason scores are, so I won't go into that. But of course, the higher your score, the more aggressive cancer looks on the microscope, the more likely it's going to come back, right? And then the last one I discuss is the PSA limbo, right? So how low can you go? So after radiation, I always tell patients, the lower the better, right? They get to 0.2, wonderful, right? If they get to 0, great. Same thing with surgery, obviously, we want to be undetectable. What do we do when this happens, right? So how do we take the evaluation approach? Well, first thing I look at is like your life expectancy, right? Because some of my treatments might not benefit you if you're not going to live more than 10 years. Just to give you an example, I think Dr. Small and Dr. Agarwal kind of mentioned fitting the Mack truck, right, into the curves of separation for benefit. Well, sometimes if you're only going to live 5 years because you have really bad diabetes or multiple heart attacks, stroke, or maybe you're 89, well, I'm not as excited about being overly aggressive, but it's also involved with like patient goals, right? How much does a patient want to be aggressive? And we kind of have this, I usually give patients a spectrum of options, like this is what you can do, and this is what you can do to do everything, right? And then we just kind of go through the pros and cons of each option. I usually, especially after surgery, will talk about patients' urinary and bowel function, especially urinary. I do not like rating patients who have urinary incontinence if they need it after surgery, because I do tell them it tends to hang around for life. It's not something I take a lot of pleasure in, so I really reinforce the Kegels. I try to see if we can watch their PSAs, and I'll touch that a point a little bit later, and their erectile function. I do say, unfortunately, if you have some sort of erectile function after surgery, and I do have to radiate you, the chances of you keeping it are not very high. But I do emphasize, for example, this is what Cialis and Viagra are for, to help you kind of preserve, or at least have an attempt to preserve that. Then we go into more of the cancer characteristics, right? So for example, I get their PSA, their testosterone, I calculate a PSA doubling time. Typically, if your PSA is doubling faster than 12 months, I get a little worried. That's something a little more aggressive, right? We get a PET scan. Of course, again, I'm not gonna go too much into that because we have a lecture coming up in a minute about that. But essentially, PET scans have been great about finding what I call like microscopic disease, or I would say not microscopic, but smaller amounts of disease that were not traditionally found on regular imaging. That's what I'm trying to show here in that top diagram with the little arrow. That's pretty tiny, probably would have been missed on more regular imaging. And then for patients who had a positive margin, I do like to either get an MRI, or I'll ask my urologist to do a transrectal ultrasound to look for local recurrence. They're both really great. And I say that in the context of, you can see around the MRI, I kind of circled it there in red. They did an MRI and they said, yeah, this area looks concerning, that there's some cancer still left in the surgical bed where the surgery was done. And it does change my management for radiation as well, right? And then we always want a biopsy to confirm that. There we go. So let's kind of just go through kind of typical scenarios. So for example, this is a patient who has surgery. He's pretty healthy. I think he's going to live for many, many years. At the time of his PSA failure, let's say it was low. I mean, by low, I mean kind of consistent with AUA guidelines, something less than 0.5, 0.2, 0.3 is what I typically see, because our urologists are pretty great about getting them back in. I ask about their continence, of course. If it's good, then I'll usually proceed forward with radiation therapy to their surgical bed, right? And then it just depends on sometimes how I modify this. Again, my own personal practice, but if, for example, your PSA is above 0.4, I get a little bit worried about the risk of this cancer going to your lymph nodes in the future. So I'll treat them prophylactically with whole pelvic radiation. If your PSA is above 0.6, some data would suggest that there's a benefit of adding androgen deprivation to reduce the risk of developing metastatic disease. But I don't just purely use your PSA, of course, because as we've seen, PSA is not entirely reflective of disease biology, but sometimes like your Gleason score might make me think one way or the other. Whether you've had aggressive features, seminal vesicle involvement, extraprostatic extension, a short PSA doubling time that I referred to before. And then it was kind of touched upon, deciphers, Artera is really, at this point, more likely deciphers, can sometimes suggest that you would benefit from either ADT or not doing ADT. Some patients ask, would I offer salvage radiation, right? So what we call this, for patients who have a PSA of less than 0.2. It's a very complex discussion. If you're incontinent, probably not. Definitely not, actually, at least in my personal practice. That's what kind of bullet point 3 is saying there from the AUA guidelines, that if you have a detectable PSA, even if it's less than 0.2, but you have some high-risk features, it's not unreasonable to do that. I really do push for them to get continence first. And then on the flip side, how about post-PSA monitoring, right? And especially in the era of PSMA PETs. Is there an approach where we can kind of watch the PSA a little bit longer than we typically would, see if we can catch something on PET? The answer is it's a very nuanced discussion, probably, but we don't know that probably to the future. So I think it's just plugging into your rad-onc and your local urologist or here at UCSF early is always a good idea to have that discussion. Very data-driven. I just want to show what a radiation plan looks like in the post-surgical setting. I think Dr. Hong did a great job of showing it in the upfront setting. And the point here is like the area in red is kind of the high dose radiation zone where we kind of boost the surgical bed for any kind of what we think is microscopic disease, right? And then this is an example where I'm treating someone's pelvic lymph nodes. That's what the kind of blue color is. And this is the dose colored gram. So hotter is red, lighter is blue, just to give you a sense of what that is. And we do a pretty nice job of, trying to spare as much rectum as possible, even though the rectum will still get some radiation, of course. And same thing with the bladder, right? And you got to see if you squint and believe that that's maybe where your prostate used to be, right? That's kind of how I describe it to patients. And to Dr. Hong's point, this is why the comfortably full bladder is so important, because the more you can fill your bladder, at least comfortably, I always emphasize that part, the less of the totality of it will get radiation. Here are some other scenarios I kind of commonly see. Again, healthy gentleman, but this time there is a positive lymph node in the pelvis on PET or maybe, post-operative MRI. Well, this person will get what I call the full Monty, right? Whole pelvic radiation, prostate bed radiotherapy. with androgen deprivation, sometimes for 2 years, actually typically, and then with, as Dr. Small mentioned, a secondary drug that will kind of block testosterone through a different pathway, right? Scenario 3, this is the one that I sometimes think about. Guys maybe don't have more than 5 to 10 years to live, but they do have a positive lymph node. Sometimes we can do SBRT just to the lymph node. The reason I don't default to that is because those patients tend to have a lymph node pop up shortly after in a different location. So you might be playing a little whack-a-mole, but I tell the patients that, right? So they're kind of mentally prepared. Or if they've had, by any coincidence, prior pelvic radiation therapy for any reason, maybe they had rectal cancer, who knows, right? And then I will actually just offer SBRT. And then the last scenario will be discussed by Dr. Hong is what do you do when the cancer's gone to the bone? How about after radiation, right? And I think this is a nice segue because we've talked about all these treatment options. So for example, if you have just purely local recurrence, it's not a common phenomenon just to have local recurrence alone, but I will discuss with them brachytherapy, which we do here at UCSF. It's called the HDR method, where they put wires in to the area of recurrence. They'll kind of just boost that area with radiation, pull out the wires, and you're pretty much done after 2 sessions, right? Then we have focal therapies with Dr. Nguyen, HIFU, cryo, and actually I just sent a patient yesterday for this exact reason. The recurrence after radiation was Gleason 3+3, probably a good candidate, focal, right to where Dr. Nguyen can go in there and zap it, right? Then we have SBRT. I don't do this as common. The data suggests that it's probably fine and safe to do and probably efficacious. It's just that usually the focal therapy has less toxicity. So let's say re-irradiation, right? And then finally a salvage prostatectomy, which, it's not a urologist's dream because the tissues are much more like fireable and they're like kind of not as going to heal as well because they're scar tissue from radiation that forms over a period of years, right? Scenario 2, we talk about pelvic lymph node positive patients. So let's say the prostate looks good, but there's a positive lymph node. Similar to my last discussion, could be whole pelvic radiation, SBRT, and then given with hormone therapy. There we go. So in short, I thought we did a nice job of talking about what PSA recurrence is, just depending on your clinical scenario. Risk factors are for PSA recurrence, no matter whether you do surgery or radiation, are fairly similar about kind of the grade, the nearby local invasion, whether it's your seminal vesicle, extraprostatic extension, your lowest PSA after treatment. And then it's really complicated. It's funny. I gave Dr. Washington a hard time. He said, post-operative radiation is fairly straightforward. And I said, Sam, it's really not that straightforward, but it's a very complex discussion that actually I feel lucky to have with our urologist here. And we usually come to a consensus before I start treatment, right? And then, my treatment personally just depends on the patient's goals, their life expectancy, what I see on their imaging, and having a goals of care discussion. But with that, I'll say thank you for your time, and I appreciate your attention. All right, I think next up we have Dr. Tom Hope, who I will say is the Director of Molecular Therapy here at UCSF. He's also one of our wonderful nuclear medicine physician and radiologists here, and someone I rely on very regularly for, Tom, is this real or not?
Okay, I wish I knew the answer to that question every time. Unfortunately, I don't always know the answer. So I'm going to talk about PSMA PET, which is sort of cool in that, historically, this was a research tool and, it's now just become boring. Everyone gets it. It's standard of care. It's sort of cool to see the thing you work on in the research realm make it out into the clinic and just be the way people are image moving forward. So we'll talk about PSMA PET. First, I just want to go through imaging modalities so we're all on the same page, right? Everyone know what this is, right? I think probably everyone in this audience has been through this machine. This is a CT scan, right? So it goes as the tube spins, it's shooting radiation through you. And what it's doing is it's measuring density. So we take images like this, which show you the density of your tissues. And we can use those differences in density to tell what is what, right? So this big thing over on the left, which you can't see, this white green dot there, that's your liver, the kidneys, et cetera. We can see lymph nodes. This is good for staging soft tissue metastases. It's commonly used, obviously, in patients with cancer. Very fast, easy, does involve a little bit of radiation. The next imaging modality, this here, we all know this one. This is the dreaded MRI, right? This is the loud machine, right? You got to wear earplugs. You're claustrophobic. We use this primarily in prostate cancer to look at the prostate itself. Okay, we're looking primarily at extracapsular extension, the images that Steve just showed there, showing T staging, et cetera, trying to determine whether or not you actually have cancer in your prostate. it's sort of neat. It actually images proton spins, which is sort of crazy to think about. You're actually imaging how these protons interact with the magnetic field, and you can somehow use that information to convert it into images, which is pretty cool. So it has a very different spatial resolution, but the tissue contrast in MRI is pretty amazing. So we use MRI as well. Now, this scanner, this is a PET CT. Okay, a PET CT images positron emission. So it's sort of a crazy technology. I think MRI and PET are the two coolest technologies in imaging, probably in all of medicine, but we'll have some disagreement with the other people in this room. But what happens is we inject radiation into the body, and that those radionuclides decay by emitting a positron. That positron then decays again, sort of a serial decay, and emits two photons in the exact opposite direction. And you can image those two photons simultaneously. That's called coincidence detection, and see where it originated from. So we can actually image where that radiation came from in the body, which is pretty neat, right? So that's what's actually neat is it's imaging within picoseconds. It can tell within 10 picoseconds where that radiation was detected and when, which is pretty amazing. So then you create images. Well, I have a slide of PSMA. I'm going to skip ahead to this image here. This is a PSMA PET, right? So this here is a whole body image, a patient sitting there with their arms above their head, right, like that. And the black, more black it is, the more of that radiation went there. And we can see where in the body the radiation goes to. So the radiopharmaceutical is excreted through the kidney. So we have the left and the right kidney here, comes out through the urine and the bladder. So that's all normal. The salivary glands up here is normal. This is relevant in the setting of therapy, which I won't be talking about today. But what we're looking for is sites like this, right? Regions where there should be no uptake, but we do have uptake, right? And that would be cancer, right? And this is tissue that expresses PSMA on its cell surface, right? So the molecule that targets PSMA binds to the tumor cells, goes inside the tumor cells, that radiation decays from within inside the tumor. We create an image like this and shows us these metastases, both the nodal metastasis and in this setting, a right humeral head metastasis. Okay, this is cool because now instead of doing a bone scan and a CT scan, we can get the same staging in one imaging study, and it's obviously much more accurate, more sensitive and specific than we get with a bone scan and a CT. So this patient historically would have gotten salvage radiation therapy with Steve, right? It would not have been very useful because he had disease outside of the prostate, and he would have immediately failed once the ADT was stopped. And now we know where the disease is, so we can treat patients more accurately. Now, there is this discussion out there of all these different agents. So there's now multiple approved agents for imaging PSMA PET out there. 3 of these are for imaging, right? So, whoa, that's not where I wanted to go. This image, this is, I can't see the screen thing on this. The top right there is PSMA 7, the most recent one that was approved. This is DCFPYL, the most commonly used agent in the US. PSMA 11 is the one we got approved. In the bottom middle, and the bottom right there is actually Pluvicto, lutetium PSMA 617. PSMA 1007 is in trials currently. The main point here I make is it doesn't matter which one. We just want to be imaged with PSMA PET. In my mind, it's a class. They all have the same detection sensitivity. Best imaging agent is the one that you have access to at whatever your local hospital is. So don't worry about, did I get imaged with Polarify or all these brand names that companies are trying to push out there. It just matters that we're staging you with PSMA PET rather than a CT scan and a bone scan. Okay. Now, the biggest issue with PSMA PET, particularly out in the community, and Peter will definitely comment on this someday, is false positives, okay? Particularly bone lesions, okay? When you have a patient at initial staging and you have a solitary rib lesion, nearly 100% of the time, these are benign, okay? But they're read out in the community oftentimes as being positive for metastatic disease, which will prevent patients from getting curative therapy. Right? That's not a good thing. So we definitely have more work to do to make sure everyone knows how to interpret these imaging studies properly. I have this case, which I like to show. This is a patient who had both a rib lesion here. So there's a rib lesion. And then there is this bone lesion here in the left pelvis, was read both as sites of metastases. On CT scan, this is a classic benign lesion, peripherally sclerotic. It's all these terms that don't matter in the patient setting, but this is not a metastasis, right? That is probably an aneurysmal bone cyst or fibrous dysplasia, something like that. That's not prostate cancer. So this patient actually doesn't have metastatic disease, totally changes the management of this patient. So what I like to say is we need to convert these false positives into true negatives, right? Through education, making sure people know what is actually negative disease, not actually miscalling metastatic disease. Outside of that, PSMA PET's awesome. Okay, now I'm just gonna build upon what Steve said. This is a study that came out of here a number of years ago, just showing patients with high-risk cancer. 53% of patients had changes in their radiotherapy planning because of findings that were seen on the PSMA PET. Some of them were because there was lesions outside in bones. Some of them were nodes outside of the field, and then nodes that were within the field that they boosted, right? So by knowing where the tumors are, the radiation oncologist can treat these patients more accurately and have better outcomes. This is still being studied in trials. The trials have enrolled. We don't yet have the outcome data, but presumably we will see good improvement in outcomes when those read out probably next year. Recurrence after radiation therapy. Okay, so I don't know why I had the white slide there. This is a patient who had definitive radiation therapy, and he had recurrence after radiation therapy. And it's a little lymph node, right? You can see nice PSMA added little node. It's actually a nice example of how the ureter right next to it can look like a lymph node, so you have to be careful to make sure you're not miscalling urine. But the thing that I find interesting about this is down in the bottom row is the radiation plan the patient had before they were treated, right? So this is the plan they had. That's the little lymph node. It was sitting there before they had therapy. It would have been nice to know that that node was there before they got their radiation, so they could have included that in the field and then gotten this treated. It's much harder to treat a node directly adjacent to a prior field due to safety reasons. So this is where PSMA PET really improves the outcome in these patients. I just put this slide in there because we're going to be moving maybe earlier. We're not there yet, but the idea of using PSMA PET to characterize intraprostatic disease. So maybe instead of an MRI, we can do a PSMA PET, or in select patients, instead of a biopsy, we can do a PSMA PET to exclude the presence of cancer, to make sure that you don't need to have your biopsy. So this is currently being studied in a phase 3 trial in Australia. So it'll be interesting to see how this all plays out in terms of how we use PSMA PET in terms of characterizing intraprostatic disease, either in lieu of MRI or in lieu of biopsy moving forward. Okay, and then there's also PSMA negative tumors. So here is a patient who has a big tumor here on diffusion on the left side, but we don't really see much uptake on the PSMA PET that's associated with that. About 5% of patients do have PSMA negative tumors. And if you have, for example, in this case, not a lot of uptake in your PSMA PET, you're not going to have a lot of uptake in your nodes. Okay, so their detection sensitivity does go down in this subset of patients who have a low uptake in their primary tumor. So overall, PSMA PET's out there, standard of care. There's actually 6 approved NDAs, right? So there's a lot for our drug, PSMA 11, because we made it generic. We don't own the rights to it, so anyone can reference that NDA and get the drug approved. There's piflufolastat, or GCF-PYL, Pylarify, RHPSMA 7. They're all the same in terms of, does it function in your case as a patient? And then I just think it's pretty cool. The PSMA PET's now really the standard imaging modality for staging patients in nearly all stages of prostate cancer, from initial staging, biochemical recurrence, CRPC, selection of patients for radioligand therapy. It has really sort of taken over the way we image and stage patients moving forward. So that was all I had to say, and I'm happy to stay here for questions later.
All right, great. Well, this talk will be about PET-directed radiation, specifically for the treatment of oligometastatic disease. Before I dive too far into it, I think a number of words have been said about Dr. Felix Fang, who is one of my mentors and friends, and he was just remarkable. I think a lot of us here have a lot to say about him. He and I used to give a version of this talk together, so you'll actually see some of his slides kind of interspersed throughout. So he actually changed his outfit so that we were dressed the same way to see if we could confuse people that day. So, all right. I often say that no discussion of oligometastatic cancer is complete without this slide, which I guess is cut off. Oh, it's cut off on my screen, but here. It's actually a slide that Felix put together. There's no conversation that's complete without a discussion of the University of Chicago. Sam Hellman and Ralph Wexelbaum there years ago had proposed that across all types of cancer, that there was this intermediate state of cancer that basically existed between localized disease and metastatic disease. And it's somewhat, I think, intuitive that there's this sort of spectrum of aggressiveness where there may be situations that are more amenable to certain types of treatments. At that point, and even still today, oligometastatic cancer has been pretty crudely defined, mostly based on the number of metastases that we see on a given image. But one of the sort of consequential things that they said now 30 years ago was that an attractive consequence of the presence of a clinically significant oligometastatic state is that some patients may have a disease that's amenable to curative therapies. And so that sort of sparked this interest in trying to treat the oligometastatic state more aggressively and potentially provide some long-term disease control, potentially cure. There's been a lot of sort of discussion around like what represents oligometastasis. How do we identify the folks that have disease that's most amenable to treatment? This is kind of one piece of the puzzle that came over from Europe with this idea of like synchronous oligometastatic disease, which is metastases that are detected at the time of diagnosis, and then metachronous oligorecurrence. That is when cancer comes back later on in very limited areas. And again, this is true for kind of all cancers that we see. And most of the data, actually, the preponderance of data in oligometastasis is in prostate cancer. And specifically, most of the data is in what we call metachronous oligorecurrence. So again, sort of in folks that have been treated before, but the cancer has come back in a metastasis in very limited areas. The Hellman and Wexelbaum theory sort of proposed that maybe we can treat these areas aggressively. And almost, in that sort of same era, there became sort of technologies that were more available to us on the radiation side, namely stereotactic body radiation therapy, or SBRT. And I mentioned SBRT earlier as a treatment modality for primary prostate cancer, but we also use it for other types of cancers, which I sort of alluded to. And we use it specifically also for other types, for oligometastasis. SBRT sort of first became popularized in brain tumors and in pulmonary tumors, and then sort of expanded to a number of other cancers. And in oligometastasis, we use it to treat areas of metastases. This is a picture of a lung metastasis for an SBRT plan that we had for a patient with oligometastatic cancer. And the idea is to treat with high precision image guidance and high dose radiation in 5 or fewer treatments. And so it was the technology that enabled very good, strong localization in real time of sometimes static, sometimes moving targets that enabled SBRT that we see today. And that allows us to deliver radiation doses that we weren't able to spatially resolve before. In prostate cancer, no one is actually intended to memorize any of this stuff, or who will actually ask if I wanted to remove the slide. But this is just kind of a representative example of all of the studies that we now have in the prostate cancer space that support the use of what we call metastasis-directed therapy with radiation. If any of you guys are readers, they're all things that you can look up. But I'll highlight that a number of them, or all of them, are phase 2 clinical trials, kind of going back to, I think, Dr. Agarwal's talk earlier. And these are all randomized, sort of earlier trials that sort of all show some type of advantage in incorporating focal radiation into the treatment of oligometastatic cancer. JAMA Oncology has nice diagrams for all of us. And so I thought I'd include this as one example. This is the Extend trial from MD Anderson, and this is actually one that tested the question of adding SBRT or not while folks were getting hormone therapy. So one of the kind of more unique questions that have been asked in the oligometastatic space. But it's a nice diagram to kind of summarize, sort of how these studies kind of come together. The idea in this study was to basically look at how long men lived without prostate cancer while their testosterone had recovered off of hormone therapy. So, and radiation increased the duration. One sort of attractive part of treating oligometastases with stereotactic radiation is that the toxicity profile tends to be pretty favorable when we treat oligometastases, and a lot of this is a consequence of how focused and tight the radiation fields are. The SABRE COMET trial was an oligometastasis trial across all different cancers, but one of the helpful elements for us in this room is the side effect profile. And so, at least in the shorter follow-up that they had over several years, there were no differences in quality of life that they found, despite treating a number of different parts of the body with SBRT. And so, as Tom mentioned earlier, imaging is getting better, and some of those trials that I showed you on the slide earlier were derived in sort of the more conventional staging era, and PSMA has certainly transformed what we're able to detect, and it's fundamentally important to how we define SBRT for oligometastases. And one of the few trials that incorporated PSMA PET scans was the oral trial from Johns Hopkins. And one of the things that they did, this is early in the PSMA PET era, but one of the things they did was they went back and looked, and even though they didn't use PSMA PET for designing the radiation fields, they looked at those folks whose treatments covered all of the PSMA avid lesions, as opposed to missing some of the PSMA avid areas. And then they found that if you, which this should, I think, is likely intuitive, if you treated all of the areas on PSMA PET, you had better outcomes. This kind of gives you a little bit of a feel. This is the x-axis is time, but the y-axis is the rate of progression-free survival. And so you can see that there are a number of favorable outcomes on this small trial. I roped Dr. Small into giving this talk with me last year, and he let me keep one of his slides, so I'm going to keep that in here too. But we often encounter the question of whether or not we should add hormone therapy onto radiation when we do metastasis-directed therapy. A number of the trials that I showed before use radiation as a mechanism to delay using additional treatment. Here we sort of try to come up with a personalized plan that incorporates considerations around both the side effects. This kind of goes to our earlier discussion, side effects and the advantages of adding on hormone therapy. A number of the study, the sort of gold standard treatment in metastatic prostate cancer remains systemic therapy. And so, the question of kind of de-escalating that alongside radiation is kind of an open one. These are some of the characteristics that Dr. Small and his colleagues, I won't put words in Dr. Agarwal's now, but this slide came from Dr. Small, but a number of the characteristics that we consider on trying to decide whether or not there's an advantage to adding on hormone therapy, augmenting the hormone therapy and whatnot. That's all I've got. Thank you.